Welcome to our literature review on glucocorticoid-induced osteoporosis, presented by Furman Budi Setiawan, under the guidance of Dr. Awalia. Glucocorticoids are commonly used to treat various diseases, including inflammatory bowel disease, SLE, polymyalgia, allergies, and COPD. Internists, rheumatologists, general practitioners, gastroenterologists, pulmonologists, and dermatologists are the most frequent prescribers. Using prednisone at doses of 2.5 to 7.5 mg daily for more than 3 months significantly increases the risk of bone loss. Other side effects include fluid retention, body lipid redistribution, hyperglycemia, dyslipidemia, and bone fractures. Osteoporosis can lead to serious health problems, including pelvic and other bone fractures, which increase healthcare costs, and pain and immobility, which contribute to patient morbidity and mortality. It is the second global health burden according to WHO. Glucocorticoid-induced osteoporosis accounts for 20% of all osteoporosis cases, making it a significant cause of secondary osteoporosis. Despite being known for over 80 years, the pathophysiology and management of this condition need further understanding. Osteoporosis is a systemic skeletal disease characterized by reduced bone mass and deteriorated bone quality, leading to increased bone fragility and fracture risk. Glucocorticoid-induced osteoporosis results from chronic exposure to glucocorticoids, either endogenously or exogenously. One to 2% of the general population receive long-term glucocorticoid therapy. Epidemiological studies show that 30 to 40% of individuals on long-term glucocorticoids may develop a fragility fracture. The risk of fractures increases with the duration of glucocorticoid treatment. Glucocorticoid therapy directly affects bone cells by decreasing osteoblastogenesis and increasing osteoclastogenesis, leading to reduced bone formation and increased bone resorption. Indirectly, glucocorticoids affect bone cells by causing hypogonadism, decreased physical activity, renal and intestinal calcium loss, and reduced production of growth hormones. These factors contribute to bone loss through increased production of pro-inflammatory and pro-resorptive cytokines. Studies show that long-term glucocorticoid use significantly reduces bone mineral density, BMD, and increases the risk of fractures, particularly in postmenopausal women. Diagnosing glucocorticoid-induced osteoporosis involves a detailed history of glucocorticoid use, history of falls and fractures, and assessment of risk factors for falls and fractures. Physical examination for diagnosing glucocorticoid-induced osteoporosis includes measuring weight and height, muscle strength tests, and checking for signs of undiagnosed fractures. Workup examinations for diagnosing glucocorticoid-induced osteoporosis include bone mineral density tests, plain radiology, fracture risk assessment, bone markers, and calcium and vitamin D level tests. Bone mineral density, BMD, is measured using T-scores and Z-scores to compare a patient's bone density to that of a normal young adult or other individuals of the same age and sex. Spine X-rays are used to detect fractures in the thoracic and lumbar spine. Nearly 33% of patients on glucocorticoid therapy experience spinal fractures. In Indonesia, BMD examination tools are limited, making radiographic detection crucial. The FRAX tool by WHO is recommended for early detection of fracture risk, based on clinical risk factors, with or without BMD fracture. However, it is not suitable for certain populations, such as premenopausal women and men under 40. The FRAX score provides a percentage likelihood of major osteoporotic fractures and hip fractures over 10 years, helping to assess fracture risk levels. Bone turnover markers, BTM, assess bone quality and remodeling speed. They are not routinely used for screening but can help evaluate the effectiveness of osteoporosis therapy in patients on glucocorticoids. In patients with glucocorticoid-induced osteoporosis, it is recommended to evaluate calcium and vitamin D levels, especially for those on long-term glucocorticoid therapy. Managing glucocorticoid-induced osteoporosis involves educating patients about risk factors, disease course, prevention, and lifestyle modifications, including a balanced diet, maintaining ideal body weight, and avoiding smoking and alcohol. Calcium and vitamin D intake through diet or supplements is also recommended. To start pharmacologic therapy for glucocorticoid-induced osteoporosis, GIOP, patients should be on a glucocorticoid equivalent to prednisone at a dose of 5 mg/day or more for at least 3 months with a BMDT score of -2.0 or lower. Additionally, those with a history of osteoporotic fractures or at moderate to high risk of fracture should also begin therapy. First-line therapy for GIOP includes bisphosphonates such as alendronate, risedronate, and zoledronate. Alendronate can be taken daily or weekly and significantly increases BMD. Risedronate reduces the incidence of vertebral fractures, while zoledronate is superior in increasing lumbar BMD. Ibandronate is also an option for those who prefer oral medication. For patients who do not respond adequately to bisphosphonates or have contraindications, denosumab or teriparatide can be considered. Denosumab is a monoclonal antibody that prevents binding between rank and roncal, while teriparatide, a PTH hormone analog, significantly increases BMD of the lumbar spine after 72 weeks of treatment. Monitoring and evaluation of GIOP should occur every 6 to 12 months. This includes BMD examination, radiography, fracture assessment, and other clinical assessments. It's also crucial to monitor side effects and safety of bisphosphonate therapy, including gastrointestinal disorders, musculoskeletal pain, and other potential complications. The GIOP management algorithm starts with assessing the patient's risk factors and BMD. If the BMDT score is -2.0 or lower, or if there is a history of fractures, therapy should be initiated. If not, preventive measures should be taken. This algorithm helps in making informed decisions for managing GIOP effectively. For patients who are given denosumab or parathyroid hormone, PTH, due to contraindications to bisphosphonates, therapy effectiveness should be monitored every 6 to 12 months. This includes BMD, radiographs, and other clinical assessments. Therapy should continue as long as the patient is on glucocorticoids or until glucocorticoid therapy is discontinued. Thank you for your attention and participation in learning about the management of glucocorticoid-induced osteoporosis, GIOP.